Hi everybody, my name is Brianne and I'm in the Acute Care Nurse Practitioner program. And for this assignment I looked at a pay-for-performance healthcare model and how it impacts U.S. healthcare. So as described in our textbook, healthcare policies and frameworks are consistently changing to try and meet our ever-evolving world. As of late, we've had increased involvement of our government and our healthcare, which everyone has a varied opinion on, as well as other organizations like the CMS or the Centers for Medicare and Medicaid Services have also been largely involved in making healthcare policy. So a pay-for-performance healthcare program simply it provides financial incentives or penalties to healthcare providers and facilities based on the quality of care that they provide for their patients. The goal of this framework is to guide their behaviors so they perform in a certain way that is beneficial to the patient, to improve their care, reduce unnecessary costs, reduce over or redundant testing, as well as improve patient outcomes. And if all of these objectives are met, then providers are compensated financially, or if they are not met, then they may incur a financial penalty. So prior to this model, healthcare providers were financially rewarded based on the number of patients that they saw within a given time frame, and that was known as the fee-for-service model. So pay-for-performance indicators, they look at a few things. The first one is the processes that are in place, and that looks at whether or not healthcare providers are counseling their patients on smoking cessation or following a healthy diet. And then outcomes looks at evaluating a couple different things. They can be looking at hemoglobin A1C levels in patients who have diabetes, or they can be looking at cholesterol levels in people who have heart disease. And what these companies are looking for is that these numbers are improving based on the prescribed regimens that your healthcare providers are instilling in the patient. Then we also have patient experience, which, like it sounds, is just the patient experience or their perception of the care that they're receiving, whether or not they are at a office or in the hospital. And then lastly, there is structure, which looks at the physical building that they are receiving their care in, how clean it is, how long they had to wait to be seen, whether or not the staff was friendly and cooperative, and whether or not there was a lot of technology in use, whether it comes to looking like at the patient portal or if they had electronic blood pressure readings, things like that. So the Centers for Medicare and Medicaid Services, first they established a value-based purchasing program which focused on improving coordination and collaboration of care for its patients that had been discharged home from the hospital. And the focus for this program specifically were on patients who had suffered an acute myocardial infarction. They had a new onset or exacerbation of heart failure, and then a pneumonia. So higher reimbursement rates were provided to clinicians and to hospitals when patients' health continued to improve outside of the hospital, and they kept up with their follow-up visits, and they remained out of the hospital for at least 30 days. Then the Affordable Care Act also implemented a pay-for-performance model through their creation of alternative payment models and accountable care organizations to promote healthcare delivery, to make it easier for patients to receive care. So these organizations, they collaborated with each other to create an easier environment to get to a doctor, nutritionist, things like that, and they are accountable for quality and the costs of services that they provide. Besides the value-based purchasing program that I explained, the government also established a couple other programs to reduce hospital readmissions within 30 days and to prevent hospital-acquired conditions like pressure injuries, fractures that had resulted from a fall, surgical infections, and then catheter and central line infections. and then hospitals are incentivized by Medicare to keep these as low as possible and prevent them from happening. Out of all of the initiatives I learned about while reading about this healthcare model, this instance is what I resonated most with in my practice at an inpatient hospital. Since we're always trying to prevent falls, we're trying to get Foley catheters out as soon as possible. We're doing the chlorhexidine scrubs on people who have the catheters and have central lines. So I'm assuming that those practices are in place because of this program. So the problem intended to solve by implementing a pay-for-performance model is improving the quality of care provided to patients in the United States, as well as trying to lower healthcare costs. In a global view, the U.S. has one of the highest amounts of healthcare costs and spending, while we also have one of the lower life expectancies, and we also have a very large number of people who have chronic comorbidities that impact their everyday life. So by incentivizing care that follows evidence-based practice, it improves care for patients and it prevents adverse effects while in the hospital. Patients are healthier and money is saved, which is a good thing. So with any policy, there are varied opinions on whether or not this program is beneficial. From all of the reading I did, most of the focus was in regard to healthcare outcomes, cost, impact on disparities or vulnerable populations, and the behaviors of the healthcare providers. So a model like this for pay for performance, it prioritizes collaboration and working together, and I noticed that the presence of financial incentives, it increased motivation in a lot of medical professionals that I found in the articles, and it also made people more apt to work as a team because they were working towards a goal. Healthcare policy researchers at the NEJM Catalyst academic journal, they also commented that a model like this, it focuses on transparency, which is good because the quality indicators that I described earlier, they are publicly reported on the CMS website. So anybody, we're all consumers of healthcare, we could all go onto the cms.gov website and we could look at the ratings for different doctors' offices, hospitals, skilled nursing facilities, pretty much anywhere you would go to receive care, you could see what marks that they were given. So this program also encourages healthcare providers to guide their practice that sets patients up for a successful life after discharge. So this is when interdisciplinary rounds and thorough discharge planning comes into play to ensure that patients are going to be successful in the outpatient setting, that they'll have access to the care they need, and that they will stay out of the hospital. So keeping patients safe while in the hospital, whether it be free from falls, unnecessary infections, it saves the hospital money and it benefits the well-being of the patient, which is most important. But on the other side, there's some authors that feel like the pay-for-performance model, it alters the behaviors of healthcare providers, which is understandable. They know that they're getting paid to act a certain way. You could wonder how authentic or how altruistic their behavior really is. Like if they're really caring for the patient or if they're just doing this for the money. This program has also been seen to worsen disparities among vulnerable populations, and some say that it lacks an inclusive study design. So data has shown that minorities and patients of lower socioeconomic status are correlated with hospitals that have poorer outcomes and have higher reporting of adverse and sentinel events. So the problem with this is Medicare does not adjust their scores for hospitals that are in poorer locations and that their patient population is typically people of color and people of lower socioeconomic status, and because of that they have more frequent financial penalties because they aren't able to meet those benchmarks. These hospitals often don't have adequate staff to do things like interdisciplinary rounding, so thorough discharge planning can't happen, and oftentimes hospital readmissions are high. Also, with poor populations in certain geographic locations, they have lower access to primary care, which that is a huge barrier to being successful outside of the hospital, because you don't have that proper follow-up to make sure that they're feeling okay and able to follow the prescribed regimens that were planned out in the hospital. So the lack of primary care turns into more frequent emergency room visits, and that also leads to more frequent hospital admissions, which if they're within that 30-day period and they're covered by Medicare, then the hospital is going to be penalized again. So this creates an issue, and it's primarily biased towards people of lower socioeconomic status. Since clinicians that work at these hospitals are not meeting the benchmarks, they're not receiving the financial incentives, they could be less likely to stay working where they are because they know they're not going to receive those incentives. And then conversely, if they do stay there if they do stay there and they do not get those financial incentives, then that's less money coming to the hospital to go towards new expensive equipment that could potentially improve patient outcomes. And then healthcare workers who choose to work at wealthier hospitals in different locations that have better access to care, they will much easily meet those requirements, and they will likely meet the reimbursement criteria, and they will be getting that money back. So I can see the bias that these authors were describing there. And then in terms of the design of a pay-for-performance model, that's been critiqued by many authors from the studies I had read. They feel some of the indicators are too complex, like the term quality of care. It does seem kind of broad and hard to measure, along with patient satisfaction. Like there are scoring rubrics in place, like you have your HCAHPS scores, which look at patient satisfaction, but both of those indicators seem hard to measure. There's also a lack of randomization when looking at the healthcare providers' caseloads, especially in the outpatient setting. Something these authors noted is that there could be biases between different healthcare practices if one had predominantly young people who didn't really have any healthcare conditions. They were just coming in for their yearly physicals or the occasional sick visit, compared to a practice that has many older adults with lots of comorbidities and lots of issues that the healthcare provider has to manage. So overall, I think if healthcare providers can act altruistically and be authentic in their behaviors to follow the guidelines that better patients while avoiding unnecessary costs, then a pay-for-performance model could be beneficial. But given our society and our ranges of socioeconomic status and the risk of further hurting vulnerable populations, that also needs to be taken into account too before deciding to implement a policy like this. So, thank you.